recording, just to let you know. And the recording will be posted on the committee's webpage shortly after the meetings are concluded today. If you are a member of the advisory committee on data issues or the advisory committee of healthcare stakeholders, or you're a presenter, please make sure you accept the invitation to join as a panelist, then mute your microphone.
Michelle, should I go ahead and get started? Anyone on?
Yeah, it looks like we have a lot of the committee members, but I'm not seeing everyone. Yeah, I think we can go ahead and get started, and then if anybody else joins after, we can let you know.
Okay. Great. Well, thank you to everyone for being here today. Welcome committee members. It is now 3:04 and I call the November 20th joint meeting of the Advisory Committee on Data Issues and the Advisory Committee of Healthcare Stakeholders to order. My name is Bianca Frogner. I am the chair of the Advisory Committee on Data Issues, and I'd like to give a warm welcome to everyone joining us today. I look forward to engaging with each of you in this continuing exciting work. So let's go ahead and open to the agenda page, which is on tab 1 of the materials specifically for the joint meeting. We'll start with a brief overview of the agenda. So that means we'll start with roll call, then we will approve the minutes. Then we will give an update of the September 19th and the November 7th cost board meetings. After the update, Joe Dielman with the Institute for Health Metrics and Evaluation will present the Analytics Support Initiative, ASI, Disease Expenditure Report, and Dashboard. And finally, Rochelle Bogue will, from the Cost and Transparency Manager, will be sharing the 2025 committee meeting dates. We will then wrap up and adjourn today's meeting. So then we'll go ahead and start with the agenda by doing a member roll call. I will call members by their first name in the order listed in the agenda, which is in alphabetical order by last name. So I'm going to start with the roll call for Advisory Committee on Data Issues Committee members. So please unmute yourself and say here as you hear me call your name. Okay, Krista.
Here.
Megan. Megan Atkinson. Not hearing Megan. Amanda. Thank you, Amanda. Jonathan. Jonathan Bennett. I'm not hearing Jonathan. Bruce. Bruce Brazier. Not hearing Bruce. Jason. Jason Brown. Not hearing Jason. David.
Hello,
David.
I'm here.
Hi, David. Thank you. Chandra. Chandra Hicks. I'm not hearing Chandra's name. Leah.
Hi, Bianca, I'm here.
Hi, thank you, Leah. Li Cho. Li Shu. Sorry, I think I mispronounced it last time too. Not hearing anything. David M. David Mancuso. No. Anna. Anna Morales. No, not hearing from Anna. Hunter. Oh, I think Hunter emailed earlier saying he was not going to be able to make it here. Mark.
Here.
Thank you, Mark. Russ.
Here.
Thank you, Russ. Mandy.
Here.
Thank you, Mandy. And Julie. Julie. Okay, thank you, Julie. Okay, any other members of the Data Issues Committee that I did not call? Or did not think that they got heard? Okay, so we'll keep an eye out on other members who join us. So now I'm going to turn to the Advisory Committee of Healthcare Stakeholders. I know some of you were here earlier, but we'll still go through this nonetheless. Emily?
Here, thank you.
Thank you. Patrick?
Still here.
Thank you. Bob?
Here.
Thank you, Bob. Paul Fishman. No, not hearing from Paul. Justin?
Here.
Thank you. Adrian Jones. Okay. Jody Joyce. Not hearing Jody. Louise? I know you heard earlier, Louise.
I'm
Louise
sorry, I had,
Thank
yes,
you.
I'm here. I just had to get off mute. Thank you.
All right, thanks. Stacy? Stacy Kessel? All right, not hearing it. Eric?
I'm here.
Great, thank you. Vicky Lowe? No, not hearing anything. Natalia?
I'm here.
Thank you, Natalia. Dulon?
Sorry, the mute button was somehow so far. I'm here.
And we have to also make sure we correct her name also in the agenda. It's also misspelled in this part of the agenda also. Michelle?
Yes, I'm here. And I was here in the earlier session, but I missed the roll call.
Okay, thank you, Michelle. Yes. Paul Schultz. Okay, Paul, thank you. Jeb? Not hearing from Jeb. Dorothy? No, you're here. Yeah, thank you. And Wes?
I am still here. Thank you.
All right, great. Thank you. Anyone else from the Advisory Committee on Healthcare Stakeholders not get called? Who is present? Or missed it? Okay. And then anyone else from the Data Issues Committee, maybe before I move on, who joined us that was not here earlier from the roll call? Okay, not hearing anything. I'll go ahead and move forward, but thank you for all who are here today. So let's go ahead and open to tab 2, the meeting summary, which is, so it's in your meeting packet, and we would like to approve the meeting summary now. As a note, the recording of the last meeting is posted on the website for future reference, or if you want to reference it anytime for future meetings. We will use a consensus vote process for a vote on the approval of the meeting summary, since June 12th was a joint committee meeting. So is there any discussion of the June 12th meeting summary or any proposed changes? Not seeing any hands. So is there a motion to approve the minutes? Hi, Russ. Yep, Russ. I don't know if you're trying to say something.
No, sorry, I just raised my hand for it. Yes, I'll make a motion to approve the minutes as written.
Okay, thank you, Russ.
You're
Is there a second?
Eric, I'll second it.
Okay, thank you, Eric. All in favor, say aye.
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 Any opposed? I'll take that as a no opposed. So we'll go ahead and say motion is approved. And we'll go ahead and move forward to tab 3, which is the cost board meeting update. Please turn to that now. And let's look at the updates from so September 19th and November 7th. I'm sorry, I'm realizing I too need to just get myself here. Okay, so I'll go ahead and review this. Okay, so the cost board on which I sit here, so these are just some updates from the last meetings that we had. So on the meeting that was held in September, we got a primary care committee update, and we had a set of recommendations that we approved. we discussed facility fees, hearing about Massachusetts Health Policy Commission's site-based neutral recommendations. The board discussed the recommendations and took a vote. Then we discussed how some of these works intersects with all payers claims database data. We had a presentation from the Office of Insurance Commissioner about the final healthcare affordability report and had a discussion about that. We had a discussion about legislative affordability priorities from state agencies, hearing from the Health Benefit Exchange and Healthcare Authority. And then our upcoming meeting is here just in a couple of weeks on December 12th, Thursday, for anyone who wants to come and listen. So the next slide. Yep, okay, here we go. Then the meeting that we had on November 7th, so that was just a couple of weeks back, we had a discussion about a best practices report. The legislature directed Washington State's Healthcare Cost Transparency Board to study best practices from other states. HMA, Health Management Associates, conducted a survey highlighting best practices across 8 states. The full report is found in the meeting packet and is also part of the legislative report. Then we had a piece about business oversight of mergers and acquisitions. Presenters discussed model legislation for overseeing healthcare mergers and acquisitions, emphasizing the need for transparency, particularly with private equity and other large healthcare consolidations. The board was advised to consider a phased approach or targeted legislation that could address high priority mergers without overwhelming regulatory structures. And we heard from NASHP, the National Academy for State Health Policy, where we discussed as a board recommendation from NASHP as a potential roadmap, particularly for provisions for monitoring private equity investments and implementing transparency measures. And then we had a discussion and recommendations regarding business oversight, where as a set of board members, we acknowledged gaps in the current oversight, suggesting to incorporate NASHP's models recommendations to address these gaps. And then as a group, the board members also recommended developing stronger ties with the Attorney General's office to ensure careful review of healthcare mergers and acquisitions. So next slide. So it was a busy meeting. We also got a report from the Analytics Support Initiative report, where they presented an update on cost growth data from 2019 to 2022 to help the board access recent, where the hope is that it helps the board access recent healthcare spending trends. You'll be hearing from Joe and ASI a little bit more today. We had another discussion about facility fees, where as board members, we agreed on the need for increased transparency in facility fee structures and private equity ownership disclosures. Then we discussed the 2024 legislative report. A high-level review of the report was presented. One of the board members suggested moving the recommendations to the executive summary. Overall, the board members supported adopting the report, and the board members supported including reference-based pricing policies to address high provider costs. So as I mentioned earlier, the next meeting is December 12th, and it's a public hearing. So look forward to seeing you there. Next slide. Okay, so then I think I'm passing this over to Joe Dielman from Institute for Health Metrics and Evaluation, who will walk through the Analytics Support Initiative Disease Expenditure Report and Dashboard presentation and then discussion.
Great, thanks, Bianca. Thanks so much. It's a privilege to be able to present today. The slides that I'm going to present today have been presented to the Cost Board in their most recent meeting. And it's important to get feedback from the Joint Committee as well. So looking forward to feedback. Next slide. So just as a reminder, the Analytical Support Initiative is a 2-year project that is funded through private philanthropy. The main objective of the project is to essentially provide analytic analyses for the Cost Board. And so it's all about providing information with a focus specifically on looking at expenditure and trends over time. That project is about 2/3 to 3/4 of the way done. And we're really kind of getting to the point where we can show some of the work that we've produced over the course of the last year and a half. Next slide. So this is just a reminder, an update of kind of the work that we've been doing. The first few months of the project through December of 2023 was really about charting our course. And so during that time, we built an analytics strategy that had 3 kind of main pillars or 3 key analyses that we're going to focus on. At this point, we have 2 of those 3 strategies complete, and that's what I'll be presenting on today. And we are making progress or beginning work on the second of the 3. So the first of the 3 key analyses were to just track spending and utilization per capita and per prevalent case in the state of Washington. We've done so by disease and Washington County. We've also looked at growth rates and drivers of change. The second piece is about risk adjustment and using age and other indirect factors and county variables to help us understand the different risks across each county. And then that's the part we haven't done yet. And then the last piece that we have done is start to look at those differences and explain those drivers. Next slide. So in April, we finished the kind of preliminary report, and I presented that to this group in June. And that report was based on previous research that my team had done at the Institute for Health Metrics and Evaluation. It was really trying to pull together previous work and put a Washington lens on it and ask the question, what could that work tell us about Washington State? Next slide. What I'll be presenting today is work that we finished about a month ago, which is a pretty serious update to that first preliminary report. And the probably key and most important innovation is that rather than extending estimates through 2019, which is what the preliminary report did, the current report now goes through 2022. And so I'll really be focusing on the last 3 years, our new estimates of healthcare spending and trends within the state. And then you'll see it's been professionally laid out. There's an actual report that is easier to read and look into and just a little glossier and makes more sense. So appreciate the support that we've gotten from professionals on laying it out. So, next slide. So the goals for today is to, number 1, to just make you aware of the updated report, to give you kind of it as a tool for your own work. And then also, we're constantly wanting to be refining this work, and thinking about how we can do it better. Like I mentioned before, we're about 3/4 of the way through this project, and that means about 25% left. And that means, there's still room for improvement and changes. Happy to take feedback from this group in particular on ways that we could tailor this research to be more useful to this joint committee, or for the cost board. And so the kind of second objective today is really just feedback on ways to make this more useful and higher utility. Next slide. Great. So as I mentioned, the really big innovation between what I presented in June and what I'm presenting today is that we now have estimates that extend through 2022. This is very new and novel. It took harnessing, most importantly, the Washington All-Payer Claims database. That's not a database that my team has used in the past. You can see in the graphic here that this is a very large data set with many millions of claims, and we add that to the many other claims databases that we're using. We know that the Washington APCD data set is not complete, but it is a great representation of a lot of the healthcare that's being provided in the state. We add to it our other data sets that are from Kythera and MarketScan, which are other private claims databases that have a lot of information about claims in Washington State. We combine those with data from CMS on Medicaid and Medicare. And then we also have data on hospital utilization from the Healthcare Utilization Project. Next slide. So this is kind of the big picture macro perspective on Washington. It's meant to be a context setting slide on where we sit. And so just to be kind of clear on what you're looking at, On the y-axis, that vertical axis, is total spending per capita in 2022 for the state of Washington. The state of Washington ranks ranks sixth and the lowest. And so you can see that vertically, it's 6 dots from the bottom, which is a good place to be. If we look at growth rates, that's what's on the x-axis. And you can see that Washington has an annual growth rate from 2010 to 2022 that's slightly above the median growth rate for the country. So each of the dots on this slide is another state. In many ways, we're doing okay on spending per capita, and we are increasing slightly faster than the rest of the country, but not a lot faster. Next slide. So this is a slide that starts to look at where we are spending our resources in the state of Washington. And so you see kind of a table here that's made up of 5 columns and 8 rows. And the 5 columns here are all different combinations of payers. So the first one is Medicaid, the second one Medicare, and then we have out-of-pocket spending, which, just to be clear, is a lot of spending on deductibles and co-payments, co-insurance. And then there's private insurance, and then the final column that's white is the all-payer population. So this is really just the aggregation of everything else. And then the rows are the types of care that we're spending our resources on. So the very bottom is the all types of care. But starting at the top, we see we have retail pharmaceutical spending. That's just the resources that are spent at pharmacies on prescription drugs. And then we have nursing facility care, inpatient medicine, hospital inpatient, I should be clear, home health, emergency department, dental care, and ambulatory care. And the places that have the colors, just to be clear what those are, is where we see growth rates that are either higher or lower. And so anything that's jumping out at you in orange or red is where that cell, that combination of payers and types of care, is growing the fastest between 2010 and 2022. So those in many ways are the places to really focus on. When I look at this table, the things that stand out that are, of importance is where we're spending our money in terms of types of care. You see that ambulatory care, which is essentially all outpatient services, is the largest category, and that is $29 billion in 2022. The next largest category is going to be hospital inpatient care with $12.6 billion. And if you think about the payers, where the resources are coming from that are spent on healthcare in Washington, is number 1 is private insurance. Number 2 is Medicare, followed by Medicaid, and then out of pocket. So in the state of Washington, Medicare, or private insurance, is by and away the largest of the payers, with Medicare kind of trailing behind it. If we want to look at growth rates, again, the oranges are the places that really jump out. So we see there's a lot of growth in emergency department care, a lot of growth in home health care. Those aren't the largest types of care that we track. You can see they're $2.2 billion and $1.7 billion respectively, which isn't a ton out of the $60 billion total that we're looking at. But those are places to watch as they're growing exceptionally fast. When we look at the payers that are growing, you see that the Medicare column is bright orange. That's, a lot of that is driven by aging over the course of, from 2010 to 2022. As the population gets older, Medicare is covering more lives, and the lives that they're covering are older as well. So a lot of growth in Medicare. During this period, Medicaid also expanded, and so you see Medicaid also has a lot of growth. And that is especially in ambulatory care and emergency department care. I'm happy to take questions. I see some in the comment. Ambulatory is broad, Justin. I'm trying to catch up on the chat, but it is. And I think that's a place that we hope to refine our estimates moving forward. Ambulatory includes, I think not only is it a big category, but the bigger problem is that includes a lot of diverse services. So it includes, outpatient specialty care, both in hospitals and in clinics. It's, your traditional primary care, urgent care falls into there, any outpatient rehab services, ambulatory surgeries, all kind of fall into this category. So there is a lot of spending. That's why you see that out of the $60 billion that we're tracking in 2022, essentially 30 billion of it is that large bucket. So,
Then Eric had a question about basically, is this age adjusted with baby boomers?
yeah, and so Eric, in a few slides, I'm going to show you, this is not age adjusted. This is really meant to just capture where is the money going. But in a moment, I'll show you slides that are in per beneficiary space. So they would be capturing essentially the fact that there's more people on Medicare in the state of Washington now than there used to be. So
Then I see a comment from Justin Gill that was cut off. So Justin, if you could maybe just revisit your comment.
Sorry. I think what I was trying to do, I actually accidentally pressed enter.
Oh,
I think definitely ambulatory care. I mean, that makes sense. Part of the problem is as well is the access to primary care, and I think that's also the fact that there's a lot of lack of access that's leading to a lot of emergency departments visit or convenience care visits. So like an urgent care when I'm seeing a patient and they're coming in for their blood pressure, I'm still billing for what a primary care doctor would bill for that visit, but I'm not really adjusting things and I'm not necessarily making sure that we're doing long-term management in an urgent care setting. And then they get billed again when they see their primary care doctor. So that lack of access actually does bloat that ambulatory care number, at least from experience. And I'd be curious stratifying that ambulatory care number out if that really does change things.
Yeah, and that is in our kind of wish list of places we want to go with this project, because I think you're right. I expect to see very different trends for the different parts of ambulatory care, and think from a policy perspective, being able to isolate where the growth is and why some of the growth is going up in more specific categories is really important.
and Louise asked or just noted that nationally it looked hospital care accounts for a larger percentage of costs than ambulatory care, but is not seeing that to be the case here in Washington. But I don't know if I see that way.
Yeah. So I think it's really important to kind of recognize that there's a whole pie and the pieces can be cut up in different ways, right? So if you look at the National Health Expenditure accounts, they use slightly different service categories to track spending. They look at hospital care, that is, more the facility fees. What we're capturing here when we look at hospital inpatient spending is going to be the facility fees as well as physician fees, but it's not going to include any outpatient work that's being done in the hospital as well.
So I think we have about 15 minutes.
Yep, I see that. I'll push forward. Thank you. Thanks, Bianca. Next slide. So we'll go through this one quickly. It's just highlighting the age and sex patterns of healthcare spending in the state. I think it's interesting and important to recognize that we spend in the state of Washington more on the 65 to 69 population than any other population. And you can see that a lot of that spending is Medicare. As I mentioned on the last slide, a lot of the spending, is Medicare spending. And we expect that to only increase as that larger population moves older in age and presumably spends more. You can see the breakdown on the left is by payer. That's where I was highlighting Medicare jumps out. And on the right, you can see that really dark blue throughout the life cycle is ambulatory care. And that's where we have a lot of spending. Next slide. So I think this is starting to get at a more specific, kind of more nuanced perspective of where this growth is taking place. And so the slide I showed 2 ago was really asking where is the money coming from and where is it going? A lot of it is going to ambulatory care, a lot of it's coming from Medicare. What we're doing now is looking at spending per beneficiary. And so here you can see that Medicare still stands out. Medicare per beneficiary is at $11,000 per beneficiary. And you can see that it's still bright orange. And so that suggests that, maybe there's an aging effect going on, but it's certainly not about just having more people in Medicare. And so that is going up. You can see Medicaid, which had more orange in the previous 2 slides ago, is now much more blue. So spending per beneficiary isn't going up dramatically in Medicaid, and where it is going up, it tends to be ambulatory care. As far as the types of care with the most growth, again, even in per beneficiary terms, we see that home health, emergency department, and ambulatory care are places where we're seeing a lot of growth. Next slide. So this is just another way of looking at the growth over time. The disaggregation here is by payer. Essentially, when we look back to 2010, we see that the state was spending just over $35 billion on health, and now we're spending just over $60 billion on health. And so you can calculate the essentially 12-year growth rates over this time period. We look at annualized rates, and the places that have the most growth are going to be some of those rows that we looked at before. In particular, we're seeing Medicare and Medicaid with some of the largest growth rates. Next slide. So this is the same thing, but now disaggregated by type of care. And so again, this is kind of highlighting the types of care we're having the most growth: home health care, emergency department care. And it's really important to see that this biggest bucket, which I know we've already talked about, is somewhat incomplete. This ambulatory care is a big hodgepodge, but it's growing really fast. Not only is it the biggest with essentially 30 of the $60 billion, but it's growing at 5.6%. So I think home health care, emergency department care, and especially ambulatory care are these categories that are growing a lot in the state. Next slide. So now this is starting to break apart a kind of exploration of why we're spending more in each one of these types of care. So each one of the columns is a type of care here. They're organized from the biggest increasers in spending to the smallest increases in spending in total amounts. Essentially going up means this is a reason or a place that we're spending more in 2022 relative to 2010. So the largest increase in annual spending is ambulatory care, and 57% of the increase in spending between 2010 and 2022 is because of ambulatory care. And what the bars do is they start to break apart why we're spending more. They start to describe or provide evidence of what are the factors that are leading to more ambulatory care spending. And so we've broken the increase up into 4 different categories. The bright orange, and we're going to use these for quite a few slides in a row. So the bright orange is population size. So we have more people in the state than ever before. And so that increase between 2010 and 2022 leads to more spending. The kind of lighter orange is the aging. And that was a question before. We know that our population in the state is getting older. We know we spend more on older adults than we do middle age or children. And so that also is contributing to the increase in ambulatory care spending. The dark purple is service utilization. So after adjusting for the number of people and after adjusting for the fact that those people are older, we can look at the age standardized utilization rates. And so this bar, the dark purple for ambulatory care and quite a few types of care, is negative. And that just means that once you've age standardized and standardized for the size of the population, we're actually using ambulatory care less than we were in 2010. So there's a reduction in spending associated with less utilization of age standardized ambulatory care. And then the last bar, the kind of elephant in the room, is service price and intensity. And this will be a theme through the next few slides, that the lion's share of the increase in spending, regardless of the type of care that we're looking at or the payer that we're looking at, or for that matter, the disease that we're looking at, really is a lot about service price and intensity. And in our analysis, we're not able to break those two things apart. We do know that for many services, prices are going up. And we also know that the average stay in many cases is using more intense care. But we are not able to, in this analysis, break those two things apart. But either way, I think the takeaway from this slide, and it will be for a few slides in a row, is going to be this real emphasis on price and intensity of care. It's not that we have older people. It's not that we have more people. It's not that we're going to the doctor more than we used to. In fact, for ambulatory care, inpatient care, pharmaceutical, and nursing facility, we're going or using those services less after age standardizing. But once we do go, it's that those services cost a lot more and they're more intense when we do utilize the services. Next slide. So this is that same slide, but now instead of looking at total spending by type of care, it's looking specifically at each payer broken down. And so there's a Medicaid column with all the types of care. There's a Medicare column and out-of-pocket spending, and then this column on the far right, which is private spending. So earlier there was a question, Medicare is going up. Is it because we're having more people or we're having older people? You can see that the light orange is that population aging. So that's the spending increase attributable to population aging. And you can see for Medicare, a lot of it is about aging. The population is older, and we know the older population is more expensive. But that's not overshadowing the fact that, you know, a lot of what's happening in Medicare is actually an increase in price and intensity. That light purple still stands out, even for Medicare, as the place where we're seeing a lot of increases. And that's really true for all of the payers. We see that for Medicaid, especially Medicaid ambulatory spending, that the intensity and price is going up per visit. And we see that for out-of-pocket spending. And then we see that for especially true for private insurance, where prices and intensity are leading to the largest increases in spending. Next slide. So this is the health conditions that we're spending money on and the change over time. So the aggregate health condition that we spend the most money on, the category, is musculoskeletal disorders, with almost 7 billion of the 60 billion that we spend. So that's almost 14% of all healthcare spending in the state is on musculoskeletal disorders. And that's growing at a rate of 4.4% annually between 2010 and 2022. The next categories with the most spending are cancers, cardiovascular diseases, and then a category that's diabetes and kidney diseases. In there, we also have this other non-communicable, which is kind of a hodgepodge of diseases that don't get classified elsewhere, but are all, by and large, chronic non-communicable diseases. Probably important to recognize is the places that are growing the fastest. So we see a lot of growth in spending on cancers, a lot of growth in spending on diabetes and kidney diseases. We see an especially large amount of growth on mental disorders and substance use disorders. Those are the two categories with the most spending that have the largest increases between 2010 and 2022. Next slide. So this is just choosing 4 of those diseases, disease categories, and asking why are we spending more on these categories that are growing so quickly. And so these are 4 different categories that all had high growth rates in the last slide. And the takeaway in some ways is very similar. We have a larger population, that's the bright orange. We have an older population, that's the light orange. In general, we're using services less, that's the dark purple. And pretty much for all 4 of these diseases, the really large increases in spending is about prices and intensity of care. Next slide. So this is now starting to take a geographic look at the state of Washington. And what we've done here is broken the state up into the counties. This is very similar to the figure that we saw, the very first figure, where on the y-axis is spending per capita, so the total amount of spending per person in thousands of dollars. And then the x-axis here is growth rates. So anything that's more off to the right is going to be the counties that are having the largest increases over time. And you can see here that the states that spend the most are King, Lewis, and Pierce and Whatcom County, all with average spending at $8,000 or above. And the counties that are growing the fastest are Chelan, San Juan, and Whatcom. And so I think it's important to see both where we have a lot of spending in the first place and also where the growth is especially occurring. I think it's worth, from an equity perspective, asking the question, some of these counties that are lower or further to the left, is it that they're much more efficient in using fewer resources, or is that they're underutilization and essentially people not getting the services that they need? And again, that's further analysis that hasn't been done, but I think important questions to ask. Next slide. So this is now starting to just take a mapped look at the spending per beneficiary. So on the top left is Medicaid spending per beneficiary, and the top right is Medicare, the bottom right is private, and then out of pocket. I think an important observation is that there are some general correlation across these four maps. The major spending for all four categories is the same counties by and large, those ones that we looked at on the scatter plot that jump out, King County being the highest for most of these figures. So, and our last slide, and then I'll come over to you, Jonathan. We just have one slide left. Last slide is looking by type of care. Can we go to the last slide? Next slide. Awesome, thank you. So the last slide is now just looking at type of care. The way that we calculate geography is by the residence of the person. So if someone lives in an adjacent county and goes to seek hospital care in a larger city, the spending is being attributed to where that person lives. So again, you can see that the lion's share of resources are kind of in this I-5 corridor, especially. And that's true for outpatient ambulatory care, but really all the types of care as well. So, Jonathan, you had a question.
Yeah, sorry, I think you just answered it. I was just curious about whether you looked at the resident of the patient and where they were coming from because of the geographic differences. In Washington State, obviously the ecosystem, you're going to see a lot of the care from rural areas.
Correct.
Going into more of the urban settings. So I'm glad that you took that into consideration.
Yeah, we think that's super important for, a lot of dense hospitals, density in the city of Seattle especially.
And Joe, I'll note there's a couple of comments that came through, one from Krista that says it's important to note that there have been large shifts in services from inpatient to outpatient in the past 5 years.
Absolutely. Yeah, that's exactly right. And that's why we can't yet distinguish between price and intensity. Especially, we see this trade-off that utilization in hospital inpatient services is going down. And we know that some of those services are being substituted by inpatient or outpatient services, which, in many cases, I think is probably an efficient substitution. But that would lead to higher spending in ambulatory care and, more utilization. We know that in aggregate, the utilization for ambulatory care still is down, but there is certainly some substitution that we see in our analysis.
And I think going back to an earlier point about kind of how these pictures are different than what you might see in the National Health Expenditure accounts is that ambulatory care includes both outpatient services connected to a hospital as well as, say, clinics that might be operating separately.
That's
You're
correct.
not able to separate those two.
Yeah.
So maybe other pictures of hospitals may include the outpatient component to hospital costs.
So ours does include the outpatient. Sorry, our hospital. Let me start over. Our hospital category excludes the outpatient and puts that into ambulatory care. I think was kind of my point. There's different ways of cutting the pie, and when you cut it in different ways, you get different leaders and who's the biggest. The way that we've done it here, ambulatory really stands out. There are certain other ways that you can cut it so that hospital looks larger. But really the growth that we see, again, in our analysis is more about this ambulatory bucket.
And then Justin had an earlier comment noting that the largest growth was service price and intensity, and wondered if billing codes, especially with 2020 AMA coding changes, may be playing a role here where ordering more tests and diagnostics were incentivized due to higher billing complexity codes.
So Justin, that's a great question. I think the important thing to remember in our exercise is we're tracking spending. And so in some cases, changes in incentives can lead to more billing, which, in many cases leads to more spending. What we're not capturing is, what the patient needs necessarily. We're just capturing the services that were provided. And so, yes, as there is incentives or just common practice to be providing more intense or more services to begin with, that's what it kind of falls into that bucket of intensity that we can't differentiate from prices.
And then Michelle asks, is there a way to measure supply side effects on utilization and spending, acknowledging that patients in rural areas are traveling to places like King County?
Yeah, we have not done that, but I think that's a great question and, a direction that we could go in the future, but haven't yet. Yeah. Thanks,
We'll probably
Michelle.
take a couple more minutes here for discussion. I think my last piece here won't take a full 10 minutes. So if anyone else from either committee wants to chime in. Dorothy.
Hi, just a follow on to Michelle's question. Are you able to measure access? It seems to me when you've all the way through this that is a key to some of this. And I'm just wondering how hard it is to measure that in a way that would be meaningful and cast any kind of light on the spending patterns.
Yeah. Sorry, Dorothy, I want to make sure I understood your question. Did you say access or excess?
Access.
Access, yeah. So what we're able to look at is utilization per prevalent case. And so that starts to get at access. And a way that we've looked at that before is, you take a disease that is maybe think of as a high prevalence disease, say diabetes, and you look at the number of outpatient per visits per prevalent case. And where you start to see those gaps is where we think that's a indication that there might be lack of access in those areas. So if you're looking at again, you want to adjust for the disease prevalence because we know across the counties, the prevalence of something like diabetes changes dramatically. But once you control for that, when you see those gaps, I think that's a pretty good indication that access is in that spot lower. And I think it also points, or at least raises questions about where there is, the other end of the spectrum, where access is maybe too good, that the utilization per prevalent case is possibly excessive or at least well above the mean. So I think those are the sort of analyses we could get at a little more. So yeah,
that might help get at some of the solutions to the spending issues.
Yeah.
Thank you.
And I see just maybe one more comment from Patrick, and then we'll have to probably turn it over back to Rochelle. So any idea why Lewis and Franklin counties are outliers on opposite ends of the spectrum? So the idea is that these are fairly two rural counties, but seeing very different pictures.
We don't, not at this point. I think our exploration is one thing that we've started to do is to make that decomposition plot and asking the question of why they're so different by county instead of over time. But even then, I think it's, a pretty coarse way. So at this point, we don't know. And again, I think that's a place for more research to really break out some of these patterns. So.
Thank you, Joe. So we're going to go ahead and turn it over to Rochelle, but thank you so much for all this information, Joe. Lots to really kind of soak in. I know it's the second time I got to see it, so got to see it with a different set of eyes. So thank you.
Yeah, thank you. Thanks, everybody.
Rochelle.
Thanks, Bianca. Okay, next slide, Audrey. Okay, so I'm going to give you guys a quick overview of the 2025 meeting calendar. The 2025 meeting calendar has been finalized, sent to all board and committee members for your reference. And the cost board will be meeting 6 times, plus hold its annual public hearing next year for a total of 7 meetings. The Stakeholder Advisory Committee and the Advisory Committee on Data Issues are scheduled to meet 4 times next year. And that includes March 27th, May 22nd, August 7th, and October 23rd. We don't know at this current time if those are going to be held as joint meetings, if they're going to be structured the same way as these meetings are, a sandwich meeting as we call them, or if they will just be separate times, like one in the morning, one in the afternoon. It's really based on the needs of the cost board and what those agendas will contain. The advisory committee on primary care is scheduled to meet once next year. And that is to look at the total primary care health spend in the state of Washington and refine their recommendations to help achieve the goal of reaching that 12% spend. And the nominating committee is scheduled to meet 3 times next year as needed. And then, of course, the schedule for any of the advisory committees may change slightly. Again, this is really based on the needs of the Healthcare Cost Transparency Board. So if they get to a point where they're planning on moving forward, making any policy recommendations, and they realize they hit an inflection point and that they need feedback and insights from the advisory committees, that may require an additional meeting or maybe some changes. But the way that we have it set up currently is that the cost board meetings are structured far enough in advance to help give us guidance and input for the advisory committee meetings. So for instance, we have the cost board meeting on January 30th, 2025, and we'll hear from the cost board about what they need from the advisory committees, and that'll help inform the work and the directives that will be put into the March 2025 meeting agendas for both of these advisory committees. Are there any questions that you guys might have about the committee meeting schedule for next year? Otherwise, I will turn it back to Bianca to wrap up the meeting.
Great. Okay. Thank you, Rochelle. So that brings us to the end of the meeting today, this joint meeting here. The recording and summary of this meeting will be posted shortly on our website. Again, thank you to Joe for his really nice, rich presentation. Our next committee meeting then is March 27th. And thank you to all of our committee members for joining today, at least for this joint piece. We will have a data issues meeting following onto this. So I look forward to seeing those of you on the Data Issues Committee shortly, and we will restart here again at 4 o'clock. It is 3:54.